Okay, let's get started. It is my pleasure today to introduce this morning's Academy Master Educator speaker, who talking on a topic I think is both near and dear to all of us here in the room, but certainly also in the folks that we work with, mentor, and try to help, which is physician well-being. Dina comes to us having gotten her undergraduate degree at NYU, College of Arts and Sciences. She was a dual major in English and biology, completed her MD at NYU, and then came here to Pittsburgh in 1979, where she completed. I came before you did. I'll leave it at that. Completing her residency in pediatrics under Dr. Oliver, who was such a special man. Went on to do a fellowship in ambulatory community pediatrics under Jack Paradise. These two are the sort of beacons of pediatrics here in the 80s. She went on to get a master's in medical education from the University of Cincinnati, and has held a number of leadership positions here in the institution. She served as the residency program director for pediatrics from 1997 to 2014, was then appointed at that time as the associate vice chair in the Department of Pediatrics, and in 2015 was named the associate dean for faculty affairs. We're delighted to have Dr. Hoffbach speaking to us this morning.
Thank you. Thanks for that great introduction, minus the time that I came here to do my residency. Good morning, everybody. Thank you so much for coming. So this is a topic that I chose to speak about because it's a synthesis of a number of themes that I have really enjoyed thinking about over the last many years. And I hope that you find something of value. I'm hoping to leave some time at the end for some discussion about the sort of what now, because what I'm going to be presenting is mainly the what and the so what, and so maybe we can think together about this. This is something that we all know. This is a summary slide of what I think of as threats to physician well-being, and you missed the first ones coming up. So there are cultural expectations of selflessness and sacrifice, right? People expect us to be like Mother Teresa sometimes. We have personal expectations of ourselves, a sense of intense responsibility, an image of the perfect doctor, and a sense of terrible shame when we don't live up to our own or cultural expectations. We don't take care of ourselves. That's Sir William Osler who talked about equanimitas, and he meant it as a sort of ability for physicians to remain unemotional as they go through their care of patients. He meant it in a good way, but many people have taken it to mean that we must not express or even feel emotion, and we stigmatize self-care. We don't seek treatment. And then workflow. Obviously, this is me, not really at the computer. We are in an era of RVU-driven productivity pressures. We have limited face-to-face time with patients, and there is an erosion of autonomy. So I consider these to be threats to physician well-being. We are often taught to look to the airline industry as models of quality and safety. So I'm looking to the airline industry here. We probably all remember this flight 1549 that took off from, I think, LaGuardia Airport into a flight of birds and went down in the Hudson. Captain Sullenberger, who was a very experienced pilot, executed a perfect landing. It was a perfect team response to disaster. No one was killed or critically injured. And everyone in the crew had PTSD for several months following this event. Poor sleep, hypertension, tachycardia, an air traffic controller, a very experienced one, needed to be removed from duty for about a month, and one crew member never returned to work. And no one went back to work immediately. And I just offer this as a contrast to what happens when we experience disasters and critical events in our lives. I'm sure you know this, that 2 medical residents in August of 2014 jumped to their deaths in separate incidents in New York City. They were both about 6 weeks into their intern year. Each year in the U.S., there are about 400 physician suicides. Suicide counts for about 11% of deaths among 25 to 39-year-olds, but it's 26% of physician deaths in that age range. Suicide is 40% higher than in the general male population among male physicians, but 130 times higher among female physicians than in the general female population. And part of this is related to the fact that when physicians try to commit suicide, they generally succeed. There's a much higher completion rate. And postmortem toxicology data reveal that there are low rates of medication treatment for known histories of depression among physicians who commit suicide. So inadequately treated mental illness is an important comorbidity for physicians who complete. This is a story that I've been asked to tell. A third-year resident in emergency medicine. I don't know if everybody knows about this. This happened about a month or so ago at a program in Chicago. Third-year resident in emergency medicine who was switching from days to nights or nights to days was found dead in bed. And she had non-toxic levels of self-prescribed Adderall in her blood. And in her home, actually she was at her aunt and uncle's home, they found 2 EKGs that were done either by her or by someone else in the ED, not prescribed, that demonstrated LVH, and she had not yet seen a physician. And her parents, her father is actually a physician, want this story told. So I'm just telling this. This is not a suicide. This was a completely preventable accidental death by a resident who was self-medicating, and obviously things went bad. Physician depression actually occurs in similar rates to that in the general population, but it's much higher among medical students and residents, and a minority of affected physicians obtain mental health services. This is a study that was done several years ago, 3 large pediatric programs. Who would think that pediatric residents are depressed? Yes, indeed, 20% depression rate, self-report among pediatric residents using standardized self-report measures. No association with demographic, sleep, or work hours, but a significant association with medical errors. They assessed medical errors in 2 ways, both self-report, which was much higher, and actual error surveillance in the medical record system. Half of the residents who were depressed reported having been unaware of their depression prior to doing the screen, and very few were receiving treatment. And obviously, suicide and depression are the proverbial tip of the iceberg. This is a photo, I don't know how many of you have seen this, that went sort of viral on the internet a number of years ago. It depicts an emergency room physician who left the ED after the death of a 19-year-old patient. And aside from the pathos of this, not very well projected picture, I'm sorry, of this doctor being alone in the parking lot grieving the death of his patient, there were many, many comments on this post, and many of the comments suggested that people did not realize that physicians grieve the death of their patients. And the person who posted this photo wrote in a comment, within a few minutes the doctor stepped back inside holding his head high again, as though that were a good thing. We know about this second victim phenomenon following medical error, a catastrophic event of medical error. This term was coined by Wu in 2000, and he said virtually every practitioner knows the sickening feeling of making a bad mistake. You feel singled out and exposed. You agonize about what to do, whether to tell anyone what to say. In a systematic review, nearly half of all healthcare providers may experience this, not a medical error with significant adverse consequences. And people use different coping strategies. Some are positive, seeking social support, accepting responsibility. Some are negative, distancing, emotional shutdown, avoidance. Those negative coping behaviors are strongly associated with distress following the event. This is a study of anesthesiologists. 1,200 anesthesiologists were surveyed. About half, a little more than half of them responded to the survey, so it's not a random sample. 84% of those who responded had been involved in at least one unanticipated death or serious injury of a perioperative patient over the course of his or her career. More than 70% experienced guilt, anxiety, and reliving of the event. 88% required some time to recover emotionally from the event. 19% acknowledged never having fully recovered. This is years after often the event occurred. 12% considered a career change. Only 7% were given or took any time off after the event. And by any time off, they meant 4 hours after the event. To understand the second victim phenomenon, we have to consider shame. Shame is the fear of disconnection, of not belonging, the fear that there's something about me that makes me unworthy of belonging, in this case, to the profession. Shame thrives in conditions of secrecy, silence, and judgment, self-judgment particularly. Most second victims struggle in isolation, both personally and professionally. And we are now using, as we know, adverse events to improve the quality of care and prevent further harm. And I would suggest that we need to use adverse events to think about the care that we provide to second victims in terms of emotional support. This is a wonderful project that was just written up a couple of months ago in Academic Medicine from a group that's studying the phenomenon of wisdom. And they used medical error and the way in which physicians recover from medical error as a way of exploring the phenomenon of wisdom. So they asked physicians to describe their paths following a medical error. There were 61 physicians who responded to a national invitation to this study. The mean age was 48, and the event happened about 8 years, mean of 8 years prior to the study. And they said, tell us a story of a medical error in which you were involved. What helped you? What made it more difficult? What advice do you have for others? And they did this, again, to think about wisdom, because errors can be, but are not necessarily, as we've seen from the anesthesiology study, formative to wisdom, because they represent knowledge and experience that's honed in the best of cases by humility. And what they found helped in this mixed qualitative-quantitative study was talking about it, disclosure and apology, which we know, the physicians developing a new narrative of the perfect, the good but imperfect doctor. They changed, those who were successful changed how they worked. They were much more likely to work on teams. They became experts in the particular domain in which they had made the mistake, and they developed increased compassion and humility. And these folks, they actually were able to describe the folks who reported the best healing as developing wisdom. So thinking beyond coping and surviving to actually developing a sense of wisdom. Report of the health of the faculty. So how are we all doing? Well, we exercise generally more than the general population. We're less likely to be obese, and we're less likely to smoke, although many have suggested that this is related to socioeconomic status rather than to actually being a doctor. But we are more stressed. We are more likely to abuse prescription drugs. We're less likely to have a PCP, and as we've said, we're less likely to seek care for medical or mental health problems. And we are much more likely to ignore both biblical and other historic Galen admonitions to take care of ourselves. I just liked this photo. We're all, I think, aware of the phenomenon of burnout. Do you want to come sit? There are chairs up in the front. Okay. Burnout, this is Christina Masloch. I just wanted people to know that this is who she is, who developed the Masloch Burnout Inventory. Burnout has been described as a deterioration of values, dignity, spirit, and will. It's related to excessive workload, chronic work-related stress, and a lack of autonomy. So we think residents when we think burnout, but we also should be thinking ourselves. It's characterized by 3 factors: emotional exhaustion, feelings of being depleted of emotional resources; depersonalization, negative, cynical, detached approach toward patients; and reduced personal accomplishment, a sense of low self-efficacy, lack of achievement, and reduced productivity. The prevalence varies by specialty among both residents and faculty, with an average of 40 to 60% among residents, as high as 75%. In that PEDS resident study that I quoted, where there was a 20% prevalence of depression, the prevalence of burnout was about 75%. Our program was not included, but I will tell you that this is true for our program as well. Burnout erodes the profession from the inside. It has an impact on us in terms of decreased attention and concentration, substance abuse, poorer decision-making skills, on patients, decreased patient satisfaction, treatment adherence, lengthened recovery time, and on the healthcare system as a whole, attrition and turnover, reduced productivity and efficiency, and associated with medical errors. Okay, now we need to just all take a deep breath. We're done with that part of the talk. So I'm going to change the conversation from what the threats are to what has been done and what we might do to make a difference. So well-being has been defined in a million different ways. I like this definition. It's a quality beyond physical and physiologic integrity that reflects the degree to which one is oneself fully and authentically, experiences connection with others and the world, and finds meaning in life and work. And I just want to say a word about the term balance, because we talk about work-life balance a lot. I think there is no such thing as work-life balance. I think there is finding connection and satisfaction in all aspects of our life and work, and it may mean that, you know, one is shunted aside for a while, but it's not so much a balancing act, and we can talk more about that. I know that many people strive for balance, and I, for one, have never been able to achieve that, but I do feel as though meaning and connection are really what it's about. So let's do a very brief review of some of the literature regarding ways of promoting well-being and reducing burnout. This is a study, stress management and resilience training. This was Department of Medicine faculty. Very small pilot study, 20 physician subjects, 12 controls. The intervention in this study was a single 90-minute session that was a combination of relaxation exercises and a sort of modified cognitive behavioral therapy. I'm not going to go into, for the psychiatrists in the room, what that consisted of, but it was kind of some brief cognitive restructuring. And the results, don't worry about the slide, showed a significant impact of the treatment, 90-minute intervention, on resilience, perceived stress, decreased perceived stress, decreased anxiety, modest overall quality of life, and no impact on fatigue. A single 90-minute session. Mindfulness. So you can pick up anything on the newsstand now, or read online. Interventions in the popular press and some of the scientific press as well, to promote mindfulness. And this is a little metaphor for mindfulness that I want to show you. I'm hoping that it works. I don't know if it will. Well, it might not. Let's see. Oh dear. I might be able to get it with this. Let's see. Apparently not. Oh, that's too bad. So what this is, I'll just tell you. This is actually from University of Wisconsin, that has a wonderful sort of integrated medicine program, and it's a video of almonds. That it's an optical illusion. There are almonds all over the screen, and if you look at the screen as a whole, the almonds are all moving in a kind of nauseating way. But if you focus on one almond at a time, the illusion is that the other almonds stop moving. And of course, that is not what mindfulness is, but the idea is that in their formulation and in what I'm trying to present, that the almonds represent all the notes we have to write, patients we need to see in the ED, the meetings we need to prepare for. And if we pay attention to all of them at once, we will be, at least nauseated, if not completely unproductive. But if we focus on just that one almond at that time, allowing us to engage our full attention in what we're doing at that moment, the motion may disappear for a little while. I'm sorry you weren't able to see that, but that's okay. So mindfulness has been described as the antidote to that frenzied movement. Mindfulness is the self-regulation of attention that allows for increased awareness of mental events in the present moment. It's characterized by curiosity. Look at this. This is what I'm feeling. Look at this. This is what's happening. Openness and acceptance toward one's own experiences as they occur. Mindful practice in a medical setting has been defined in this wonderful article by Epstein in 1999 that I highly recommend. He describes mindfulness as integral to the professional identity of physicians. Mindfulness allows us to listen attentively, to be aware, become more aware of our own mental processes in the moment, to become flexible and recognize our own biases and judgments as they occur in the interview, and to deal with strong emotions that arise both in the patient and in ourselves, and to make difficult decisions, to act with clarity and insight, and with principles and compassion. And I would add, to experience the most wonderful thing in medicine that we can experience, which is awe. This is another study that it was specifically designed to promote mindfulness. There is a program at the University of Massachusetts called Mindfulness-Based Stress Reduction. I refer you to the internet to find this. It's an 8-week program that you can actually do online. It's completely free. This study of family medicine physicians squished the 8 weeks into a weekend and 2 subsequent evening sessions. At baseline, the subjects had high emotional exhaustion, high depersonalization, but high personal accomplishment, which is actually very common among physicians. But they were technically burned out. And following, so what you're seeing here are the baseline measures here. So high personal accomplishment, high emotional exhaustion, high depersonalization. One day after this 4-session intervention, we see a decrease in these measures and actually an increase in personal accomplishment. 8 weeks after and 9 months after this intervention, significantly better scores on all 3 domains of the Maslach burnout inventory. And there were also, not shown in this slide, a significant impact also on depression, anxiety, and stress among these subjects. Obviously very small, but interesting results. Another study, 74 physicians at the Mayo Clinic. This intervention was a 19-session, every other week, 1-hour facilitated discussion group among a group of physicians. And the intervention, so over these 9 months of every other week sessions, the intervention, people sitting together, talking about mindfulness, engaging in mindfulness activities, discussing meaning in work, sharing reflection and shared experience. There was a control group, and there was also a non-trial cohort, because at Mayo, interestingly, they survey all of their physicians on measures of burnout, engagement, stress, routinely during the course of the year. So just to point these out to you, let's just start with finding work oh dear. Anyway, there was improvement on all measures of them. I'm not going to try to go back. The whole thing may blow up. There was improvement in all measures of the burnout inventory, improvement in finding work meaningful. And what was most interesting is that the full impact was not realized until a full year following the end of this 19-week intervention. The non-trial cohort, the control group, got 1 hour off every other week to do whatever they wanted, and they had their RVU requirements adjusted accordingly. They got a little bit better, actually, than the non-trial cohort. The non-trial cohort got worse in all of these measures over the course of the year plus 9 weeks. So I'm so sad that this video won't work, because this is a fabulous video of kids talking about and demonstrating in the moment breathing exercises. So we've talked so far about kind of interventions, an hour intervention, a 19-week intervention, a 4-session intervention. There are things that we can do, obviously, in the moment. And how many of us have just taken a deep breath? So this is a very cute video of kids. And one of the things that they say is, one child says, the heart plumps low, the heart plumps lower, and it goes to your brain. He's describing what deep breathing does. And another kid says, she's shaken off this bottle of sparkles, and she says, it's like the sparkles just go to the bottom of your brain. It is so cute. Maybe you'll find the link and see it. It's really quite wonderful. Yes. Yeah, please.
Study. When you said that the intervention group got the hour off every other week.
No, the intervention group got the 1 hour of mindfulness talking about things. Control group got 1 hour off every other week, RVUs adjusted so that they could do whatever they want. They had a free hour.
They got better than baseline, but not
Correct.
As much as the mindfulness.
Correct.
Okay.
Correct. They got worse than baseline, but not as bad as the non-trial group. The only group that improved was the group that got the intervention.
So there were 3 groups.
Yes.
Business as usual, an hour off,
and this mindfulness intervention. Oh, and I should mention, thank you for reminding me of this, although it said 19 sessions, the mean number of sessions attended was actually 11. So they didn't, not everybody got to every session by any stretch. Okay, that's the video that won't show. And so after this really cute thing of the kids, I'm just going to show you some of what they actually were saying. There is a literature here. I'm not going to describe it for you, but there is a huge literature that looks at the central nervous system effects of mindfulness-based stress reduction. And basically what they're saying is the heart pumps lower and goes to your brain, and the sparkles go to the bottom of your brain, because that's actually what is happening. Another technique, aside from deep breathing, meditative breathing, is what we think of as a mindful pause. And we all know this image of a high diver standing, in that moment before he or she flings himself off into space, sort of pausing for a moment. And it has been suggested that we do that every time we're about to walk into a patient room, in the ER, in the hospital, in the clinic, just a moment of collecting ourselves in preparation for every encounter. And as you might expect, in 2016, there's an app for that, and you can actually download. Does anybody have these apps on their phone? They are phenomenal. Just reminders, right? Should you forget about deep breathing or a mindful pause, they will actually remind you. And I just want to mention this brief compassion meditation. She's given me permission to say this, but our dear colleague Sarah McIntyre, when she walks into the room of a patient in the hospital, a child in the hospital, particularly a severely ill or severely disabled child whose parents are not in the room, she will say at the bedside before launching into her exam of the child, a very brief, what's called compassion meditation or metta prayer in Buddhist prayer, which is simply some variation of may you be safe, may you be happy, may you be healthy, may you live life with ease. Just a very short little prayer that for her kind of marks the beginning of a connection with that child.
She says it out loud to the child or in her brain?
I think she says it in her brain. I think you can say it in your brain. When you do this, because it's actually self-compassion. You start, if you're doing it in Buddhist ways, you say this to yourself, and then you say it to people who are close to you, and then you say it to people who are sort of neutral, and then you say it to people who are your enemies. And the idea is that you say it to all sentient beings, and the idea is that you sort of send that compassion out into the universe. So this is a very brief little snippet of that. Gratitude. So we know that in every culture, in every religion, in every age, philosophers, artists, sages, Piglet, and even Elie Wiesel, who spent his youth in a concentration camp, talk about the value of gratitude. We know that gratitude is associated with well-being. We know that people who are feeling well experience high well-being, frequently experience gratitude. But the question is, can gratitude promote well-being? Can the actual practice of gratitude cause us to have a better sense of well-being? And as you might imagine, this has been studied. There were 3 groups, 2 groups of college students, 1 group of patients with chronic neuromuscular disease, randomly assigned within groups to a gratitude group, just 5 minutes at the end, depending on the condition of either each day or each week, thinking about things that had happened during that day or that week that made them feel grateful. A hassles group, you can imagine, which is frequently the group that I'm in, or a neutral group that was just asked to focus on things that had happened during the day. And they recorded daily or weekly, again, depending on the condition, affect, coping, health, symptoms, and an overall life appraisal. And yes, the gratitude group, these were random assignments, reported feeling better about life as a whole, had fewer physical complaints, spent more time exercising, reported being more optimistic, and had improved amount of sleep and quality of sleep. And these were, again, these were folks who had, were either random college students or had a chronic illness. suggesting that gratitude actually, as a deliberate cognitive strategy, actually just focusing for a few minutes, either each day or each week, on what we are grateful for, can actually change how we experience our lives in many ways. I just want to spend another moment on self-care. So Peabody in 1925, I think addressing the graduating Harvard Medical School class, said the secret of the care of the patient is in caring for the patient, a lovely expression of humanism in medicine. More recently, Candide, actually writing a feminist perspective on medicine, said the secret of the care of the patient is caring for oneself while caring for the patient, suggesting that it does not have to be an either-or, and that really in order to be the best possible at what we do, we really need to be well. This includes humanism toward ourselves, including acknowledging our imperfections, our fatigue, our mistakes, our discomfort with medical uncertainty. And particularly as educators, as suggested by Novak in this article, we have an obligation to share with our learners how we ourselves have coped with anger, anguish, shame, or uncertainty. When we think about well-being, we think about things that we can do ourselves to promote our own sense of well-being, finding meaning in work, maintaining perspective, practicing gratitude, maintaining a sense of humor, etc., etc. Rituals like music to release the tensions of the day. Some of our rituals involve 2 carbon fragments, but we would actually say that's probably not the best ritual for promoting well-being. Nurturing ourselves, taking care of our medical and mental health needs, getting exercise, spending time in nature. Spirituality, actually, not necessarily religion, but spirituality has actually been shown to be very effective or very, very well correlated with a sense of well-being. And these are groups that I think you've probably heard of, groups that focus on peer support for well-being, the Balint groups. We have a sort of what we call a taste of Balint in pediatrics. These are groups where, and I know in psychiatry and certainly in family medicine, there's a great deal of focus on Balint groups in which groups of, in this case, physicians come together. It's not consciousness raising. It's not a support group. It's actually a group that facilitates the bringing to conscious awareness the struggles that we have emotionally in taking care of certain types of patients or certain patient situations, and the group sort of takes care of the person who's telling the story. And then I don't know how many of you have heard of Finding Meaning in Medicine. This is a group that started in Northern California by Rachel Naomi Remen, who wrote those fabulous Kitchen Table Wisdom and My Grandfather's Blessings. They have recently moved, believe it or not, to Dayton, Ohio. The dean of the Boonshot School of Medicine must have gone out there for a workshop and found it to be even more transformative than I did when I did this, and she bought the program and brought it to Dayton. So these are wonderful. There's an online discussion group. There are guides for starting one's own. They're usually groups that meet about once a month in someone's home and talk about a variety of topics. The theme is finding meaning in medicine and connecting to the meaning of our work with each other. So where are we as a medical community in promoting well-being? And I'm going to suggest here that most of what I've talked about so far are things that either we can do ourselves or things that groups of us can do. But I think the institution has a responsibility, a shared responsibility with us. So this is a study, actually, that looked at the impact of organizational leadership on physician burnout and satisfaction. They surveyed 3,000 physicians on the leadership qualities of their supervisors. They surveyed them on burnout, and they surveyed on satisfaction with work. And what they found is that positive leadership qualities, including informing, engaging, inspiring, developing, valuing, were significantly associated with less burnout and increased satisfaction. In fact, 11% of the variation in burnout was correlated with the leadership qualities, and 47% of the variation in satisfaction. So there are organizational factors that impact well-being, right? The efficiency of the practice environment, how much flexibility and autonomy we have about our own schedules, what our workload expectations are, and as this study suggests, what the characteristics of our leaders are. Okay, I said that right, sorry. Well-being has been integrated as a competency in the Canadian system. This is the 2015 Physician Competency Framework that includes the at least aspiration that physicians will demonstrate a commitment to our own health and well-being in order to foster optimal patient care, and includes this language: mindful and reflective approach to practice, resilience, responsibility to self, including personal care. The ACGME, our very own ACGME, has milestones, at least in pediatrics. I didn't look at internal medicine and psychiatry, but maybe they're there as well. And that is that residents should engage in, these are aspirational, these are the level 5 milestones, habits of engaging in help-seeking behaviors and explicitly role modeling these behaviors in others, deliberate practice, continuous reflection, etc. And I'm told that the new guidelines, the American Board of Pediatrics is revising its professionalism standards so that this summer there will be new material on humanism, self-care, well-being, and the value of mindfulness and reflection on professional identity formation. The AMA has this amazing program that I had not seen until I did this, prepared this talk, called Steps Forward, that has interactive modules that you can do that actually I think you can even earn CME credit for them. Imagine that. So check that out. And then the AMA Wire, the American Medical Association, has this website, How to Boost Joy in Medicine. Check it out. This is a curriculum that I'm so excited. I participated in the development of, and it has just been published. It will be available online. It's published by the American Academy of Pediatrics section on palliative care, and it's a 4-part curriculum that includes the part that I contributed to, which is communicating in difficult situations with families, but also includes a section on promoting well-being. It's focused on trainees, but it's got fabulous material in it for all, and I will let you know when it is actually available. So, what would it look like? What would an organization look like that supported physician well-being? We would be given, we would structure time to process after critical events, including explicit care for second victims. We would provide mentoring and peer support for personal and professional growth and models of mindful practice. We would have some programs, somehow sponsored by the institution, to promote and cultivate mindfulness. We would pay attention to workflow in ways that we might not be paying optimal attention to right now, including having some autonomy, some flexibility, some control. We would develop our leaders perhaps in somewhat different ways than we do now, talking about self-awareness and relationship skills and valuing of the people who report to them. And we would be investing in each provider as a precious resource, and really valuing, communicating value to those individuals. And it has actually been suggested in this wonderful article in Lancet in 2009 that physician well-being might be considered an organizational indicator of quality alongside patient satisfaction and serious harm events because of the impact that we've already talked about of physician well-being on patient care and on the institution. So we need to be well. We are physicians with the responsibility to care for patients. We need to be well so that we can bring our full attention to each patient encounter. We are faculty with the responsibility to teach, model, and create an environment that fosters learning and growth in our students and trainees. We need to be well so that we can give a clear message to our learners that it is important to take care of ourselves and to ask for help. And we are a community of colleagues, and we need to share with each other and with our learners how we have coped with our feelings of anger, anguish, shame, or uncertainty. We need to acknowledge imperfection, foster reflective practice, and hopefully develop ourselves on the wisdom path. So I am going to close, and I left a little bit of time because I do not have the answers for how to do this, but I suspect that as a community, we might have some ideas. So if you would like questions, comments, thoughts, and we can go forward. And I'm really sorry about those videos. They were so cute, but you can find them on your own. Thank you very much.